Thank you very much. Good day, honored mentors, colleagues, and friends. If you can hear me well, please let me know. Is okay?
Hear you loud and clear.
Very good. Thank you very much. I'd like to thank the organizers of this convention, the Egyptian and World Neurosurgeons Community Academy and Endoscopic Spine Foundation India. Specifically, my friend Dr. Anand Kavi and Professor Malcolm Pestonji for the invitation and for eagerly pushing through with this conference despite the pandemic. I'm in the Philippines right now and we are still on lockdown. Recently, I'm under quarantine. Recently, my resident who's undergoing training became positive with COVID-19 and I was exposed to her last Friday, so I have on voluntary quarantine. I'm going to turn off my video to maximize my, speed, internet speed, if that's okay. I will be giving an experiential presentation about the philosophy of learning that I used in cervical endoscopy and how I developed a new technique or a new approach to solve high cervical C2-3 disc herniation causing spinal cord compression in my patient. I have no disclosures and nothing that will affect my presentation. Percutaneous endoscopic cervical decompression covers both anterior and posterior approaches. I will introduce a new approach which hopefully some of you will consider if you are faced with the same case or cases that I will present. First, to discuss how I learned this technique and how I incorporated it in my practice, I will use the Fitz and Posner model of motor learning. 60 years ago, Fitz and Posner proposed a model of motor learning and skills acquisition that centered on 3 stages. In the now classic theory, performance was characterized by 3 sequential stages: the cognitive stage, associative stage, and the autonomous stage. The cognitive stage marks the period in which the goals are established and used to determine the appropriate sequencing of actions to achieve the desired goal. Learning at this stage generally involves the use of explicit knowledge. Movements are slow, inconsistent, and inefficient. A good example that comes to mind is when we learn how to swim. We look and observe at someone swimming, how they are enjoying it, and we decide that we want to learn how to swim. And we will probably do dry swimming and first do this dry swimming and reenact the movements and rationalize the need for each movement to complete a set of strokes, taking into account the breathing, arm and feet strokes, and body turns. On the action sequence, once the action sequence has been determined, the learner enters the associative stage in which attention may be focused on the specific details of the sequence. Determining the appropriate subparts and transitions, the movement is now executed in a smooth and coordinated manner. Movements are more fluid, more reliable and efficient, less cognitive activity is required. This is where the learner understands how each movement is linked with its other movements to create a whole. While at this stage of learning, I divide the procedure into the approach stage, which is understanding relevant radiologic and endoscopic anatomy of the approach. The endoscopic decompression stage, understanding endoscopic view of the pathoanatomy and related structures. And endpoint, knowing that the compression is enough and making a clockwise evaluation of the operative field before ending the procedure. Autonomous stage is wherein the execution of movement or techniques requires less attention and cognitive demand. This happens when the sequences of basic movements become more automatic and the surgeons can free his mind and are able to anticipate surgical events and dangers and recognize impending disasters, thus able to prevent and adjust focus on demand. Even at this day, in this day and age, where we have explosion of knowledge and the formation, a lot of information exchange, the old saying that experience is the best teacher still holds true. We learn from the experiences of our own pioneers and mentors. We how we understood. We also learn from our own experiences how we understood the basic steps of our procedure, and slowly we try to do training and research to understand some more. That the transition of associative stage to autonomous stage is a continuous back and forth process. Your sense experiences becomes knowledge, and a specific visual spatial motor cerebral pathway is formed that makes the learned or acquired skill automatic and is used in practice. To illustrate this process of learning, I will use a case of a 48-year-old female teacher who complained 4 months non-remitting right shoulder and arm and hand pain. With a pain score of 8 to 9, it's slightly relieved by elevating the arm above the head. Pain somewhat decreased in intensity in the 3rd month prior to admission. However, she developed progressive numbness and weakness on the right arm and hand. 1 month prior to admission, the pain recurred. The dosage of medications were increased and rehab physical therapy was initiated with minimal relief. The neuro exam and the EMG NCV showed right radiculopathy at the C7 distribution with weakness of the grip but with no Hoffman's. Her MRI is consistent with C6-7 right foraminal stenosis, and she was scheduled for a PECD C6 to C7 on the right side. And here's my OR setup. If you can remember the associative stage, until now, I still continue to divide the procedure in 2 stages or steps that will guide me and the operating room staff in the conduct of the surgery. For this procedure, the approach stage includes localization of the C6-7 V point using C-arm and docking the cannula and endoscopically visualizing the V point by removing a thin layer of the muscles. So you can see very well the V point. The endoscopic part of the approach is the unroofing of the foramen by doing laminotomy and medial facetectomy. This is accomplished by using endoscopic Kerrison and endoscopic drill. And we can see here the Kerrison removing the ligamentum flavum and exposing the endpoint for this approach stage, the exiting root and the thecal side. Once the bone work is carried out, the lateral ligamentum flavum is removed. Once the dural anatomy has been clarified and the location of the herniated disc is confirmed, endoscopic decompression commences. So here we can easily remove the disc and it's very important to go and above and below the lesion to make sure that the disc is totally removed. So here we can see some more views. We do exploration and then endpoint after exploration. Now, going back to the Fitz and Posner model, I would like to propose an addition to the continuum of the stages of skills acquisition. This is the stage of advancement or formation of new knowledge and expansion of indications and application of new techniques. And this I will illustrate using another case. In the last quarter of last year, 2020, the Philippines was visited by 4 typhoons that brought plenty of devastation in my province, and the one hardest hit was my province in the Bicol region. Our 49-year-old social worker was then very active in relief operations. She complained of sudden dizziness and tingling numbness of the neck down to the feet upon lifting packs of relief goods. She claimed that before sleeping that night, she already noted some unusual tingling sensation of the right shoulder and arm and hand. The numbness progressed to weakness and inability to walk, and she developed electric shock-like sensation from the neck down associated with head movements. Peculiar in this case is that the patient already had a right-sided upper extremity and left-sided lower extremity paresis from a childhood poliomyelitis. However, she's a fully functional person. Also, it's very important to note that in the history, she had a history of thyroid surgery with modified radical neck dissection 5 years prior for thyroid cancer surgery. The neuro status preoperative is this one, and the patient is really bedridden. The MRI showed a spinal cord compression with edema from a C2-3 disc herniation, and the disc height, though, is not compromised. How do I help my patient? So I had to do my research. The case is not common. The overall incidence of C2-3 disc herniation is 0.2 or less than 1%. Approaches had been elucidated in cadaveric studies. Submandibular approaches were described, as well as transoral approaches. Surgical approaches to the upper disc level have been performed for inflammatory, neoplastic, traumatic, and infectious process. So these approaches are familiar. Here is the illustration of the open submandibular approach. A detailed anatomic study of the open submandibular approach by Russo in 2009, published in the journal Neurosurgery Spine, showed the intricate anatomy that the surgeon need to master to ensure a safe approach. And this was discussed with the patients and the relatives, and they were not amenable to have this procedure done. There is also a transoral transmandibular approach for maximal exposure, and literature describes that the transoral approach, which can maximize the exposure with additional mandibulotomy and glossotomy, but these approaches were maximally invasive and as well not advisable to be used for a small lesion like in our case. And this shows the coverage of the transoral approach. Now I have a dilemma. I asked for help for a discussion with the online discussion with my mentors in Korea, and they advised an anterior C3 transcorporeal approach. And however, the patient has a previous modified radical neck dissection, so I said this is a contraindication. Now my options will be transoral approach or endoscopic approach, and I tried to look for a publication about C2 transcorporeal approach, and I cannot see one in the literature in the internet. So there have been published articles in anterior and transcorporeal approaches, and this was 2009 and 2016. I'm going to show you the serial photos of the planning stage, this for the discussion with the relatives. And this is the positioning that I've done with my patient. The patient is on head holder, Mayfield, with 2 nasogastric tubes, one for the suctioning and one for going to the stomach. And you can see here the GAG mouth gag to open the oral cavity. And this is my docking of the approach after cutting the a small 1.5 centimeter incision in the mucosa. And first I did a reamer on the C2 and then reaming up to the canal. And this is a X-ray on lateral. You can see the drill and the forceps going through the C2 transcorporeal tunnel. And the first endoscopic view that I can see is this one. It's inside the disc, and I can fully, with some right angle dissector, I am able to remove the disc hernia there and clearly decompress the disc hernia. This is the point where I had to remove part of the annulus fibrosus after removing the disc herniation in front. And this is very important step. However, I did not remove the final annulus fibrosus fiber for fear of dural tear, because dural tear I will not be able to manage with the transoral endoscopy. So this is the endpoint. This is your C3 end plate, the remnant annulus, the lateral wall of the bone tunnel, a thin layer of the posterior longitudinal ligament, and the C2 end plate. And still pictures of how it was removed. And the last photo, you can see here the edges of the scope or the tunnel, or rather the cannula, which is 1 centimeter, and the opening of the bone is just 5 millimeter. And you can see here the opening in the mucosa, and upon closure, post-operative 3D reconstruction, you can see anterior and posterior, and the bone tunnel is there, very small, and the X-ray post-operatively. Neurostatus post-operative, after 2 weeks, the patient's biceps improved, the hand grip improved, the left improved, and the hand grip on the left also improved. The patient is now back. Sensory is 80% from the neck down. The patient is ambulatory with improved bowel and voiding function. So the take-home message is that an endoscopic transoral transcorporeal approach for spinal cord compression is a viable option. Learning is constant. That's same as Dr. Alfonso Garcia mentioned. And you have no choice but to learn, and we have to individualize our care and respond to patient-specific needs. The advancement stage is the formation of new knowledge, expansion of indications, and new techniques, and is an outcome of a continuum of learning as you go into autonomous stage, and a necessary ingredient in solving a problem using a new philosophy. Thank you very much for your kind attention.